Why did you have a 30-year-old?
Well, just turned 29, so years are
Come on, how hard?
Hold it down till the big green light comes on.
Oh, hold it down until the green light
There
comes
you
on.
go.
Okay, all right. Hi, good afternoon. Good afternoon. It's noon, so let's go ahead and get started. I'm Shelby Ike. I'm here to talk about skin cancers. We're going to talk about, this is a general discussion. We won't get into terrible specifics about treatment like margins and things like that, but it's a general overview, primary for primary care and not so much for dermatologists or plastic surgeons. I'm going to start off by trying to convince you that it's an important topic. And the things that we'll talk about are, the first 10 or 11 slides will just be going over statistics and things. And what I want to illustrate is that skin cancers are very common. They can cause mortality, especially melanoma, and that they can cause significant morbidity, and that these things can be reduced by early detection, thus the importance of early detection and treatment. And primary care doctors are in an excellent position to find many skin cancers. So first, they're very common. Basal cell and squamous cell carcinomas are the two most common cancers in humans. The last year for which we have data was 2012. There are 5.4 million new cases. That's compared to 3.5 million new cases 6 years prior, and only 1.6 million cases of all other types of cancer combined, except in situ. So you add breast, bladder, everything else. There were 1.6 million cases in 2012 and 5.4 of skin cancers. Reporting of basal cell and squamous cell is not required, so this is likely an underestimate. Now, melanoma is the 5th most common new onset cancer in both men and women last year. If you exclude basal cell and squamous cell, which would be number 1 and 2 otherwise, melanoma is 7% of all new cancers in men and 5% in women. And that is an increase from just a few years prior, so the incidence is still going up. The probability of developing a melanoma in the U.S. is about 1 in 27 lifetime risk for men and 1 in 40 lifetime risk for women. And if you think about it, that's almost 1 in 4 men and 1 in 2.5 women in their lifetime, which is a lot. Those statistics are taken from American Cancer Society Cancer Facts and Figures, which they published every year since 2005. The next is the incidence of melanoma in Alabama. To put together this and the next few charts, I went through the American Cancer Society Cancer Facts and Figures for the last 15 years, and I got the numbers out for each one. They only go back to 2005, otherwise I would have gone back further. But you can see that the risk goes up and down a little bit, but it's trending up from basically 900 in 2005 to a little over 1,500 in 2020, anticipated in 2020. That's similar for the incidence of melanoma in the U.S., which was about 60,000 in 2005 and about 100,000 is estimated for this year. Men get a little bit more than women, but the incidence is increasing in both. Next, skin cancers can cause mortality. There were 3,400 deaths in 2015, the most recent year for which we have data, for non-melanoma skin cancers. And you tend to think basal cell and squamous cell, they're not going to cause death. And thankfully, I've only seen 2 or 3 in my practice. But it can be surprising. People will let them go and let them grow. But also some of them have specific mutations which can make them more aggressive. Melanoma accounted for 7,200 deaths last year. But it's not one of the top 10 causes of cancer deaths, which is interesting because it's the number 5 cancer for both men and women, but not even in the top 10 for deaths. The 5-year survival rate, this just shows the improvement over the past few years. It's gone up from 82 to 88 to 94% over the last 20 to 30 years. Now this is melanoma deaths. You'll notice that they increased from 2005 to about 2016, and then a significant decrease through last year and hopefully a little bit more again this year. And there are two probable reasons for that. One is there has been a push for early detection for years, and hopefully what's happened is even though we're finding more and more, hopefully we're finding them earlier when they're more curable. Also, with the advent of the new immune medicines, that is likely a cause too, although I don't have data to support that. Skin cancers can cause significant morbidity, and we all see small skin cancers and don't think that much about them. In the past 2 weeks, I've seen 2 or 3 patients brought to me because their skin cancers had grown big enough that the family couldn't be in the room with them. And what can happen is the skin cancers can grow, they'll outgrow their blood supply, and that causes necrosis, and that is unpleasant to be around. Late last year, I saw a patient with basal cell cancer. It was the first time I had met him. It involved the entire ear, the parotid, the cheek, down the ear canal to the tympanic membrane. Now that's not surgically curable, but you hate to see those sorts of things in the United States. They really shouldn't occur, but they do. I've had to remove all of the ear in several patients, half the ear in several patients. I've seen about 7, 8 patients lose their entire noses. So these are not mortality events, but it is significant morbidity. And a lot of the times what happens is this patient does see doctors and other people and just nothing ever gets done about it. So I want to try and impress upon people that it's best to find these things early, and they can be found early. A lot of the times a patient will come in and say, oh, this spot doesn't hurt or itch, I don't need to do anything about it. But only about 1/3 of basal cells or squamous cell carcinomas will have any symptoms whatsoever. So the fact that they're asymptomatic is not reassuring. Primary care doctors are in an excellent position to find skin cancers. I see a lot of skin cancers that are found by primary doctors on routine visits. A lot of the times the patient won't notice a skin cancer. I see a few physicians, some retired, some currently practicing, and I find skin cancers on them that they don't see. Sometimes it's on their back, sometimes it's on the shoulder, sometimes it's elsewhere. But it's easy for a person not to notice the cancer on himself or herself. We tend to think of things as what we're used to. If we have a bump on our skin, we've all had pimples, we've all seen moles or warts, and we tend to think it's something like that. If we've never had a skin cancer, we're not thinking about that. So a lot of the times patients won't think that, it won't even enter their mind that it could be a cancer. A frequent thing in men is an ulcer that won't heal in the hair-bearing face. So I keep hitting it with my razor. A lot of the times people think it's a mole or a wart or a foreign body. I have a real nice patient I've seen for years, and he was certain that the nodule in his hand was part of a tomato plant because he was a tomato farmer. And he would not let me biopsy it. I kept saying, I think it's a cancer. No, it's not. I said, I tell you what, it's so small, the tomato fibers would be so small that I can't just pick it out, so let me just shave a little bit of it off. We'll let the pathologist find the tomato in it. And sure enough, the pathologist found squamous cell carcinoma. And then he did let me treat it. But it was really just figuring out that that's what it was and letting him know to let me treat it. So if the patient doesn't notice it or isn't worried, they won't mention it to the doctor. So a good skin exam during regular physical exams or admission to the hospital or whatever the situation may be often will find a skin cancer that the patient didn't know about. Okay, a couple more slides and then we'll get to some photos looking at them, but risk factors for skin cancer. Far and away, UV light damage is the most important. Primarily UV light damage as a kid. There have been some studies, which are certainly not perfect in the way they were performed, but where they looked at people of similar qualities, similar color skin, eyes, so on and so forth, that were raised in the South, like South Florida, for the first 15 years of their life and then moved up north, and similar people that lived up north for the first 15 years of their life and moved south. The people that grew up in the South, spent their earliest years in the South, got many more cancers. So the implication is that the earlier you get sun damage, the higher your risk. We all have seen lots of sun damage. We're all at least everyone in this room is working in the South. You see the dry skin. Sometimes it's thin and atrophic. Sometimes it's thicker and leathery. Oftentimes lots of wrinkles. A lot of the times dyschromias like freckles, lentigines, things like that. Light hair, skin, and eyes. I would mention that not all people that get skin cancers are light-skinned. I have removed melanomas from very dark-skinned women of African descent. Not a men, just a few women. And I've removed squamous cells and basal cell carcinomas from people from Asia and South America with very dark skin. It is a small minority of the people that get skin cancers, but it is still possible. The World Health Organization finally came out in 2009 and said tanning beds are carcinogenic to humans, which is important because the tanning bed people will say, oh, we don't have that kind of UV light, so we don't cause skin cancers, but that's not true. All right, let's see. Sorry about that. I pushed the wrong button. Okay, a few more risks. Personal history of skin cancer, many moles. That would be 50 or more. That's an increased risk for melanoma. Immunosuppression. Transplant patients get several times more skin cancers as well as more lymphomas. Ionizing radiation. Chemical exposure, one big one would be arsenic, and that would be pressure-treated wood. People that, not anymore, but that's what pressure-treated wood used to be, is treated with arsenic. It worked really well. The wood lasted forever, but the people that produced it got skin cancers. HPV, chronic inflammation. That would be something like a wound that won't heal, an old burn site. If you have a patient with an old burn site that hadn't healed and the burn was 30 years ago, that warrants a biopsy, because there is a type of squamous cell carcinoma called a Marjolins ulcer, which occurs in old burn wounds that won't heal, and cigarette smoking. Okay, now one slide about basal cell cancer, then we'll look at a few pictures because I think it's good to hear the description, but it's much better to see actual pictures of it. So there are three types of basal cell carcinoma: superficial spreading, nodular, and sclerosing. When we talk about the different types of cancers and precancers, there's a lot of overlap. So I think the most important thing is just to be able to recognize, does this lesion warrant biopsy or not? And if you think it's a basal cell and biopsy it and it's a squamous cell, well good, it needed a biopsy and you figured it out. But I don't think it's that helpful to try and definitely say it's a basal cell or a squamous cell or something like that. Just try to realize whether or not it needs a biopsy. So superficial spreading is thin, red, pink plaques. Nodular, we've all seen it. It's pearly, raised, sometimes a central dimple or ulceration. Usually it's flesh-colored. Sometimes there can be pigmentation in it. Sometimes some telangiectasias or spider veins are in them. Sclerosing looks more like a scar. The borders are hard to see. It can be slightly indented, can be flesh-colored. These are two basal cell cancers. The vast majority of these are patients that I've treated, so most of the photographs are pretty good. A couple I didn't get as good as I thought. With this, you can see, hopefully it shows up well enough that you can see the pink on the slide on the left, and then the much bigger pink with slight erosion on the right. These are fairly typical. And if anyone has any questions, just speak up during the talk. Two more. The picture on the left, we're not talking about the slightly hypopigmented area. We're talking about the pink spot in the middle. And that was a basal cell cancer. The one on the right is typical with nodularity. It's flesh-colored. The picture doesn't really show it. It's a little bit pearly, slightly translucent when I examined him. Then a couple more. These are more textbook ones. Both are pearly, nodular, with the pink spider veins or telangiectasias. Both of these are typical nodular basal cell cancers. The one on the left is another typical nodular basal cell cancer. The one on the right You might not pick out basal cell cancer, and frankly, I'm not sure that I would pick it out, but I would say that whatever that is, it shouldn't be there. And it is a basal cell carcinoma, but a pigmented one. Earlier I told you that some people will let the skin cancers grow fairly large, and then it can be a much bigger deal to treat them. The one on the lady's forehead on the left, it was about 3.5 centimeters in diameter, but thankfully with that one we could just remove it in the office. The patient on the right, take a second and realize just how big that is. It went down to the collarbone, and that is a basal cell carcinoma, or it was. I removed it about 10 years ago. An orthopedic surgeon helped and removed the involved portion of the clavicle. The nice thing about basal cell carcinoma is it would be very rare for a basal cell carcinoma to either metastasize or cause death. But that does allow them to grow very large if neglected. And thankfully I've been seeing this guy for the last 10 years. He's well. He's done just fine without a good portion of his clavicle. He's had a few more skin cancers, but none that have gotten anywhere close to that size. All right, squamous cell carcinoma. With squamous cell carcinoma in situ, the first line is very similar to the first line of basal cell carcinoma, a red plaque and scaly. And they can look fairly similar. Sometimes it's white hyperkeratotic. Keratin's a protein in the skin, and if it overgrows, it's white and rough. There's well-differentiated invasive squamous cell carcinoma. Those are usually flesh-colored or red. There may be a scab, maybe an ulcer. A lot of the times the patient will have that and say, oh, well, I just keep bumping it or keep hitting it with the razor or something. But an ulcer that won't heal over a month without a well-defined explanation should be biopsied. I'm not talking about diabetic foot ulcer. Those clearly frequently take longer than a month to heal. But a scab that comes for no reason on the face or really anywhere else should be biopsied after a month of no improvement. Sometimes they'll look like a wart, a cutaneous horn, an advanced actinic keratosis, and sorry, I'll get to actinic keratosis in a minute. It's sort of a pre-squamous cell cancer. Cutaneous horn, that's simply made of keratin. Our fingernails and our hair are keratin. And we can have growth of that keratin that looks just like a fingernail anywhere on the body. And it's a cutaneous horn. Many of them do have skin cancers in them. There's another, there's the keratoacanthomatous type squamous cell cancer, and I mention that because it grows very rapidly. The patient will come in and say, yeah, it was first here 6 weeks ago, and now it's 3 centimeters in diameter. And the inclination would be to think, there's no way, it's been there a year. But those will grow that fast. And they will say, yeah, I saw my primary care doctor, he referred me to you, I'm seeing you 10 days later, and it's grown since then. The good thing is that if a keratoacanthomatous type squamous cell carcinoma has a very good prognosis, even though it grew rapidly. One thing I would like to mention here, although it does apply in other places, if a path report ever shows perineural invasion, that indicates a high risk of recurrence. And the thought is that there's invasion that sort of skips down the microscopic nerve, so even a free margin, there may be something out past it. So that requires really wide excision and usually radiation. I mention it under squamous cell carcinoma because that's where I've seen the most. About 1 in 1,000 skin cancers has it. But I've also seen it in basal cell carcinoma and breast cancer too, and it can happen in any type of cancer. So if you ever see perineural invasion, that warrants special consideration. Now some pictures. I hope they're showing up better over there than on what I have. But the one on the left side is just a pink area on the hand. There might be a little bit of keratin in it. Doesn't look terribly worrisome, but it was a skin cancer. The one on the right is, I know it's hard to see, it's at the sternal notch. It's not the hypopigmented area, it's just above that. It is a keratin nodule. When I saw it in clinic a couple weeks ago, I thought it was going to be an invasive squamous cell carcinoma, but it was just in situ, thankfully. This one on the right this patient's ear shows the whole gamut of actinic keratosis to squamous cell carcinoma. The biggest white nodule is invasive squamous cell carcinoma. Then more close to the, more anteriorly is a squamous cell carcinoma in situ, and then about halfway down the helix is an actinic keratosis. I know that because I biopsied all of them. So you can't kind of see the progression from actinic keratosis being thinner and a little bit rough and raised and white to the nodular squamous cell carcinoma that was invasive. The one on the patient's cheek is also an invasive squamous cell carcinoma. I think most people, if you saw that, you'd say that's not right, it needs to be biopsied. This one on the left is another hyperkeratotic one. It shows up perhaps a little better. Then the one on the right is the flesh-colored nodule with the central keratinaceous plug. Sorry, I marked it before we took the photo, so it's got the purple, but it should be pretty clear what it is. Just a couple more fairly typical. The one on the left, it's not the yellowish nodule, obviously, it's the pink nodule. And then the one on the right, that could look something like a basal cell carcinoma with a central ulcer. It's not, it's a squamous cell. But again, one of the points being, the biggest deal would be to be able to say that doesn't look normal, it needs to be biopsied, not specifically saying it's a squamous cell or basal cell beforehand. Like this one on this patient's medial canthus, I looked at that and I thought it was going to be a basal cell carcinoma. It's a little pearly, it's got telangiectasias, but it was a squamous cell. The one on the right isn't what you would expect, certainly not a textbook description of a squamous cell cancer, but it is too. The patient on the left is one I saw a couple weeks ago. His family brought him in because, as you can see, there's some necrosis there. And what's happened is the tumor's grown large enough, it's outgrown its blood supply. The central portion and a little bit distal has necrosed. And they said they couldn't get in the room with them. So they brought him and we removed it, and it was a squamous cell. I put the ruler there just to show how big it is. The nodule itself is just shy of 3 centimeters. And a similar but smaller one on the right side. All right, with melanoma, we probably all know the 5 risk factors. It's A, B, C, D, E. Asymmetry, then border irregularity. The border can be indistinct, it can be serrated. Color, lots of different colors can be worrisome. Shiny black, violet, red, blue. Variegated, multiple colors can be worrisome. 1% of melanomas are not pigmented, and they are sometimes a little more difficult to diagnose. Diameter greater than 6 millimeters, most of our patients still don't think in terms of millimeters, but they do remember the yellow pencil they had in school. So if you take that yellow pencil and you try and cover the lesion up with the eraser and it doesn't work, then it's bigger than 6 millimeters. And evolving would mean changing over weeks, not I bumped it and it bled. It would be, it looked this way and over the past few weeks or maybe months, it's changed. So some pictures of these. On most of these, I went ahead and wrote down the thickness. There were a couple when I took the pictures from the computer with the patient's name and just labeled them as melanoma, some of them I forgot to put the thickness. So some of these I won't have the thickness listed. The one on the left, it's a brown, slightly variegated lesion, clearly greater than 6 millimeters. It's asymmetric, and it was an in situ. The lesion on the right, we're looking at a brown raised nodule on a lighter brown irregular base. So that one's pretty straightforward that needs a biopsy. These two probably don't look like the classical melanomas, but each of them is asymmetric with indistinct irregular borders and variegation. Both of them are significantly greater than 6 millimeters. So both of these warranted biopsy and then excision. These are kind of more textbook melanomas, each of them dark, shiny, irregular. The one on the left just looks kind of wild. It has irregular borders, hypopigmentation in the center. I think most people would look at that and say that should be biopsied. The melanoma on the right is amelanotic. It's not pigmented, and it's nodular. So, the biopsy might be thinking basal cell or even something else, but this was an amelanotic melanoma and a fairly thick one. Next are a couple much more rare melanomas. The one on the left is subungual. The melanoma itself is not under the part of the nail that you can see. It's a little bit more proximal, but because it's in the matrix, you couldn't see it on the skin. And so what happens as the nail plate is made and grows out, it carries some of the pigment with it. That's why you see the linear streaks. Now sometimes you can get a melanoma in the matrix. The matrix is what the nail is held on by. So the matrix under the cuticle makes nail plate, and the matrix past the cuticle holds on to the nail, basically. So if you have a melanoma in the visible part of the matrix, it may look very similar to if you just hit your thumbnail with a hammer and have a hematoma. They look very similar. The difference being that if someone comes in with a lesion that looks like that, and you say, well, did you bump it? Yeah, I slammed it in a door or something. Well, that makes you think it's likely a hematoma, but that should grow out. So in 6 months, that should be completely gone. If they say, yeah, I slammed my door in my thumb in a car door a year ago, and they still have it, they shouldn't. That's probably warrants a biopsy. If someone comes in and they just did a few days ago, you can just watch it. In 2 or 3 months, it should have grown out a couple millimeters. The one on the right, I think that is the right heel. You can't really tell from this photo, but this lady was a very dark-skinned lady, and so dark-skinned people do get melanomas too. This melanoma, gosh, I removed 11 or 12 years ago. I can't remember. It's been a long time ago. And last time I saw her was about 6 months ago. She's still doing well. This is the survival rate for melanoma. And again, they don't publish these all that often. The biggest point is from 2000 to 2011, there's improvement. Specifically, I don't just say local disease when I talk to patients. I consider stage 1, 2, 3, and 4. Stage 1, generally a 5% chance of it coming back over the next 5 years. Stage 2, about a 20%. Stage 3, which would be lymphatic involvement, a 50% chance of it coming back over the next 5 years. And with distant metastasis, a 20% chance it won't come back, or an 80% chance it will. That's all assuming treatment. The patient that has a melanoma that doesn't treat it, of course, their odds will be significantly worse. And the importance of that is, you find a melanoma a millimeter thick, you got a 95% 5-year disease-free survival from treating that. If you find one by the time it gets to the lymph nodes, you have a 50% 5-year disease-free survival. And you've had to remove the lymph nodes, and they've undergone immunotherapy, or maybe chemotherapy. So that should underscore the importance of finding it early. Now, we'll just talk about some precancers that are some precancers and some benign lesions that are very common and sometimes can be confused. Actinic keratoses, we see tons of those in the South. They're not cancer, but they have an increased risk for turning into squamous cell cancer. An older term is solar keratosis. I prefer actinic keratosis, and the only reason is it's a simple, silly reason. If we quit calling them solar keratoses, then it'd be easy in my clinic notes to write AK for actinic and SK for seborrheic keratosis. But because we still get path reports that say solar keratosis, I don't feel like I can write SK and be very clear. Regardless, most of the time people are calling it actinic keratosis now. It is the most common premalignant lesion. Depending on the study you read, between 1 and 10% will turn into squamous cell carcinoma. Now, actinic keratoses can be 2 or 3 millimeters and barely raised, or they can be 10 millimeters and raised by 3 millimeters. So there's a tremendous variation. And that probably is what's responsible for the variation in the risk of subsequent squamous cell carcinoma, depending on the different studies you read. A lot of the times people that have them have many of them. They'll be in the sun-exposed areas. Basically, mid-arm down to hand, the V of the shirt up. You have them other places too, but those are the biggest, most common places. They can be white, rough, hyperkeratotic, or they can be pink and sometimes kind of scaly. A couple examples. This one close to the ear on the left picture, it doesn't look that different from one of the basal cell cancers and one of the squamous cell in situs that I showed. So, a lot of the things, appearance can overlap a little. The one on the right looks to me a little bit more like a squamous cell, but it was an AK because I did shave it off. This picture, I'm sorry, it doesn't show quite as much as I was hoping it would. There are numerous pink plaques on this patient. They just don't show up in this photo. They show up a little better there than on my screen, but it's just an example of how a lot of patients that have one have many. The next very common lesion people get in the South is seborrheic keratoses. They're raised, waxy, stuck on appearing. They look like you could peel them off. You can't really, but they look like you could. They come in all colors, flesh-colored, orange, gray, tan, dark brown. A lot of the times they fit the description of the ABCDE for the increased risk for melanoma. And there's a lot of overlap, so I frequently see patients that come in and say, well, this meets the description for melanoma, and it meets the description for being evaluated. It doesn't mean that it's a melanoma. There is no increased risk of malignancy with seborrheic keratoses. This first one's a fairly typical example. It's raised, brownish in color, fairly regular borders. But then these, there's one in the photo on the left and a bunch in the photo on the right. All of these are greater than 6 millimeters. Most of them have irregular borders. They're variegated. Parts are raised more than other parts. So on just describing it, it does meet the criteria for being evaluated for melanoma, but when you look at it, when you see enough, you realize that that's a pretty straightforward seborrheic keratosis. That being said, in making a decision whether or not to biopsy something, if I'm not absolutely certain, I look at making my decision about if I'm wrong, which is going to be easier to defend in the future. If I let a melanoma go because I think it's not, and then it spreads, that's hard to defend. If I put a small scar on someone and then later they complain, I've got a scar, I don't want this scar, I'll say, yeah, but I was worried it could have been a melanoma. And it's pretty easy to defend doing a biopsy. So if there's a question, it's pretty easy to just go ahead and do a biopsy. Lentigo, this is very common. They can be light, medium, or dark. They're flat, usually a well-defined border. They can be solitary or multiple. They are an indication of sun damage, and we see a lot of them. This lady in the lateral canthus and temple has several, and then the patient on the right has numerous on his back. They don't have an increased risk for malignant transformation, but they are a marker for sun damage. The next lesion I'm going to show you has nothing to do with skin cancer, but it's something I see every couple years, and so I'm just going to put it in there. So if you see this, you know, hey, maybe I need to check it out. Both of these nodules look very much like cysts, except they're a little pinker. Normally a cyst, sometimes it doesn't cause much of a contour change because it's subcutaneous. Sometimes it does create some contour change to where you can see it just by looking, but it's not typical for them to be pink. Merkel cell cancer is a fairly aggressive cancer that's very rare and is usually diagnosed by surprise when removing something that you think is benign. So if you see something that you think is a cyst that's red and you think, okay, it's infected, I give the patient a prescription for an antibiotic and the redness doesn't go away, then there are two possibilities. It could be still infected, or it could be something else. So at that point, it's probably worth evaluating. Now, I know some people do biopsies and things like that, and some don't. So I'm just briefly going to talk about the options to work up and treat a skin lesion. I'm not going to get into margins and radiation and chemo and all that sort of stuff, but because this is geared toward primary care. The first option is do nothing. If it's benign, that's a great option. Topical agents, 5-fluorouracil. Of course, we all remember uracil being a pyrimidine, and it's used when the RNA is used in duplicating DNA. But you put a fluorine on the uracil, and then it can't replicate. So the way that works is the actinic keratoses, and it also has an indication for early squamous cell or basal cell. I don't use it for that, but I do use it some for actinic keratoses. Those cells are rapidly dividing, so the 5-FU gets into the cells as they're replicating, and it prevents it. And so then what you get is some ulceration and an unhappy patient, and then you stop the Effudex after 28 applications and it gets better. Effudex and Fluoraplex, which are two trade names for 5-FU, is not that pleasant to use, but it works very well. Imiquimod has been around for about 16 or 17 years. A friend of mine was at Research Park in North Carolina when they were doing the clinical studies on it. They're not absolutely certain how it works, but it does work on AKs and early basal cell and squamous cell. Again, it's not that much fun to use. When we use one of those, I use 5-FU more. When we use that, we get a lot of calls from patients because they've gone from having all these rough raised hyperkeratotic white areas or pink smooth areas to now having tons of small ulcers and lots of redness, and eventually it starts to hurt. We've all seen fever blisters, but sometimes these patients may have what look like 15 or 20 fever blisters on their face. They don't like that, but it does work very well. Cryotherapy stings a little. It hurts some people a lot. It hurts some people not at all. It varies from person to person. Basically, you're doing the 28 days of application all in about 5 seconds. And then the patient gets to start healing. It works very well on thin lesions. It does not work well on thick lesions. I would refrain from using it on anything that could be a melanoma or have an increased risk, because it can, the melanocytes' production of melanin is significantly damaged by hypoxia and by cryo. And I have seen a few melanomas of unknown primary, and meaning they have a lymph node with melanoma in it, or they have a subdermal melanoma that clearly is an in-transit metastasis, meaning it's gone from the primary toward the lymph node basin, but didn't make it, and it took root deep to the skin. And then in those patients, I do a really thorough exam, and most of the time I can't find the primary. And it could be that maybe the immune system took care of it, or maybe it's amelanotic or non-pigmented. So I wouldn't use cryo on any pigmented lesions that could be either melanoma or a nevus or a dysplastic nevus or anything like that. The next is photodynamic therapy. It's kind of hard to get approval for this. You got to try everything else first. You got to try cryo and the topical agents. Basically, you're sensitizing the actinic keratoses to a light, and then you treat them with the light, and the sensitizer means that the AKs take up the light with more intensity, and it is supposed to destroy them. The surgical methods would be tangential excision, incisional biopsy, or just full thickness excision. For lesions that are superficial, tangential excision works very well, because if it's an actinic keratosis or an early thin squamous cell cancer, a lot of times you'll go deep enough, you will have diagnosed it and treated it all in one procedure. Let's say that it's a big lesion. A lot of times it's easy to just shave off a little bit of it for a biopsy. Now, that's not intended to get the whole lesion, but it will give you a tissue diagnosis so you know what to do next. Incisional biopsy where you actually take the blade perpendicular to the skin and remove a small portion is done probably not as frequently in the patients that I see. It is good for something that's very big that you think may be a melanoma because you want to go full thickness. When removing a melanoma, the margin I take is dependent on how thick it is. So we need to have an accurate estimate as to how thick it is. And whether or not you take lymph nodes also depends on how thick it is. So the importance of determining how thick it is cannot be overstated. The only downside of an incisional biopsy is if you have a melanoma that is, say, 3 centimeters in diameter and you take a ½ centimeter portion of it, you may end up getting the thinner part of it, and then you go and take it and remove 1 centimeter margins, but then your specimen in the OR says it went deeper, you have to take more. I've only had that happen a couple times though, but it's very frustrating. But incisional biopsy is a very good way of making a diagnosis. Next, a lot of these things, like that big one that had ulcerated on that patient's forearm near his hand, and the family said his room smells and we brought him to you nothing looks like that needs to stay. I assumed it was a squamous cell carcinoma. It could have been a basal cell. So I actually didn't biopsy. I went straight to excision. It was that big around, 3 to 4 centimeters. The lesion was about 3 centimeters around. The excision was about 3.5 centimeters in diameter. We don't have enough skin to close that on the forearm, so I put a skin graft on it. The report came back. It was a squamous cell carcinoma, and he's doing well. More typically, you go straight to full thickness excision if it looks typical for a cancer, and you can just remove it and sew it up. I tend to do a lot more going straight to full thickness excision now than I did when I was first in practice, but I've treated 10 or 20,000 of them, so if it looks pretty typical, then I feel fairly confident in going ahead and removing them full thickness the first time. The take-home points are skin cancers are very common, as we talked about, 5.6 million the last time they were recorded. They have a potential for morbidity. It can be mild or it can be severe. And they have a potential for mortality. Not a tremendously high potential, especially when treated early, but that is the importance of early detection. We can reduce the morbidity and mortality by early detection and treatment. As part of routine exams, it's important to do a skin cancer exam. I have a lot of patients sent by primary care doctors who were just doing a good full exam and they noticed something. Maybe they biopsied it, maybe they didn't. But I also get referrals from the cardiologist or the orthopedic surgeon who's seeing someone for something totally unrelated and just happens to notice it. Occasionally I have a patient that was getting his or her hair cut, and the hairstylist noticed it. So just paying attention and looking at the skin will frequently find cancers that can have better results by being treated early. And probably the most important thing is if a lesion is not clearly benign, biopsy it or refer it for biopsy. And that's it. Does anyone have any questions? Yes?
There was an instrument that came out some time ago that measured the thickness of skin lesions. Is that something you wouldn't find wayside?
Yeah. That's not done clinically. The only thing that's done clinically as far as measuring the thickness of a lesion, of course, that would be melanoma because that's the only one where the thickness is prognostic. That's done under the microscope from the basement membrane deep. And so it's not done clinically.
So that didn't work out?
No. I've never even seen the device, and it hadn't made it to where it's in clinical use. Yeah. Yeah.
What makes you decide to do a graft versus flat?
He asked what makes me decide to use a flat versus a graft. A lot of things. Some of those things are the patient's condition and preferences, but also sometimes they're anatomic. Let's say we have someone who's older, not in the best health. that needs the quickest, easiest procedure, that typically would be a graft. I can do a graft in the office, up to about 5 centimeter diameter in about 30 minutes without putting the patient to sleep. That is a fair number of shots, though, to get it numb. To do a flap that size, you tend to have to anesthetize a lot more tissue. And so a lot of the times that would require a trip to the operating room so the patient could tolerate all the injections. Patient preference. Sometimes you get someone who says, and I'll describe both, and they'll say, I want the graft because it's quicker and easier. Or they'll say, I want the flap because it looks better. Then there are anatomic reasons. Let's say, for example, in a common scenario, a cancer is involving the helix of the ear. Now, the helix of the ear, or the outer rim, is much thicker than the skin on the other parts of the ear. So if you do a skin graft there, it'll look a little bit like a shark bite. And some patients might not mind that, particularly if they're really infirm. But a lot of patients would mind that. So I can do a postauricular flap. That is where you imagine the skin that is immediately posterior to the ear on the head. You lift it up a little bit, attach it to the defect in the helix. Now you can't completely cut it free because it's too thick to survive as a graft. So the blood flow from the postauricular area will keep it alive until blood vessels from the ear grow into it. And then 6 weeks later you come back and then you can trim it and make it look good. On the nose, for example, a lot of the times, particularly in the lower half of the nose, a lot of the times a skin graft doesn't look all that good in that area. And a flap will look a lot better. Sometimes, particularly, let's say it's full thickness in the nose, and I've seen more than I'd like to, considering the country we're in. A lot of the times there, I've seen skin cancers where resection went all the way through the nose. Now the patient's got 3 nostrils, or one that's a lot bigger than the other. To reconstruct that, a graft is not a possibility. In that case, you need to reconstruct the lining using mucosa, the support, that would typically be cartilage from the ear, and then thicker flap skin generally from the forehead. And you can get a nice result doing that, but it is a much bigger procedure. Hence, we want to find them earlier. So those are the primary things that go into making the decision. What else?
I saw something recently about there's a new technique where they use a certain wavelength of light to determine whether certain moles are cancers. You know anything about that?
I haven't heard that specific one, but I know dermoscopy has been around for a while. And that is, if anyone remembers looking at slides under high magnification, what you do is you look at the slide, then you put a little bit of oil on it, and then you put the magnifying glass, the part of the ocular on the microscope, and then you put that in the oil, and it lets you get a much higher magnification. And you can do that on the skin. That's been done for several years. The early studies with the 2 or 3 people that did a lot of it said that they felt like they were more able to tell a melanoma by doing that than just by looking at it with the naked eye. It hasn't gotten widespread adoption, and Medicare won't cover it, but there are still people that use it for that reason. I haven't trained in it, so I can't claim any specific expertise in it. But the papers have been very interesting. What else? All right, thank you.
Thank you.
Okay.
So literally, when you get ready to go, you can just hop back up there and start.
Okay, so 5 minutes then? Should we wait?
You
Till-
wanna wait 5? Okay, whenever you get ready.
So we don't have to wait till exactly 1:30? We don't have to wait till 1:30? No? All right. So just introduce myself and, okay. Ready? Okay. So Chris Verico, I'm an assistant professor at the Baylor College of Medicine in the Departments of Psychiatry and Pharmacology, and a principal investigator at the Michael E. DeBakey VA Medical Center. So today we're going to talk about cannabinoid use for pain management, and I have nothing to disclose except for the fact that I received an honorarium for this, and I will be discussing cannabis or marijuana, as well as dronabinol, which is a generic name for Marinol and Syndrose, cannabidiol, and nabilone, as far as off-label uses of currently approved medications. All right, so what comes to mind when somebody thinks of a marijuana user? Now, for some people, it's going to be smoking a joint, some dude smoking a joint, and if you've seen any of the movies from the 80s and 90s, then it's probably going to occur to you. If it was about 100 years ago, you might think about reefer madness and all the negative effects that have been associated with marijuana. However, today, an increasing number of people are thinking about marijuana as a potential therapeutic agent. And in fact, before the 1930s, even the government itself thought that cannabis had medicinal value. And this, in fact, dates back and before recorded history. And the earliest written reference to the use of cannabis for medical purposes dates back to 1500 BC, when it appeared in the pharmacopoeia, the Chinese pharmacopoeia. It wasn't actually put to any scientific analyses until 1843. The first scientific assessment was published, and it was shortly after that that the U.S. Pharmacopoeia actually added cannabis to its list of medications, and it included treatments, the use of cannabis for treating things such as tetanus, rabies, alcoholism, opioid use, etc. Subsequent additions expanded definitions in use, and then with the 1930s and the negative press, or the propaganda, if you will, it was actually pulled from the U.S. Pharmacopoeia in 1942. So the question is whether or not there is actually valid scientific evidence to support the claim that marijuana and cannabinoids have some medicinal properties. And today, this talk aims to educate you on the scientific knowledge currently available on the endogenous cannabinoid system, which is also called the endocannabinoid system, or ECS, as you'll see it abbreviated in the talk. The potential therapeutic properties of medicinal cannabis and other cannabinoids, and to be able to compare and contrast the advantages, disadvantages of cannabinoids with opioids, at least some. And at the end of the talk, hopefully you'll be able to describe at least 3 unique characteristics of the endocannabinoid system, describe at least 3 potential therapeutic purposes and clinical indications of cannabinoids, and then identify the currently available cannabis-based pharmaceuticals in the US market, and I do discuss one that is not currently available. So we now know that that humans have an endocannabinoid system, as do other animals. These include the cannabinoid receptors, the CB1 or the cannabinoid 1 receptor, and the CB2 or cannabinoid 2 receptor. Endogenous cannabinoids, and these include anandamide, which is abbreviated as AEA throughout the talk, and then 2-arachidonyl glycerol, or 2AG, as well as enzymes that are involved in the production and the degradation of both of these endocannabinoids, including FA, which is fatty acid amide hydrolase, and MGL. So starting with the cannabinoid 1 receptors then, they weren't cloned until the 1990s, and so it took a long time before scientists actually understood how cannabis affected people. There are more cannabinoid receptors in the brain than there are the mu-opioid receptors, which is where opioids work to produce their analgesic effects. And so we now know that the heavily labeled sites in brain include the basal ganglia and the cerebellum. And this underlies the effects marijuana has on movements. They're found in the hippocampus as well as the prefrontal cortex, and this is the well-known effects of amnesic effects of cannabis use, at least the acute effects, as well as on a working memory, the perception of high and things of that nature. And they're also found in the hypothalamus, where they regulate things such as production of reproductive hormones, and it stimulates appetite. And while there are few receptors in the brainstem, especially in the areas that control cardiorespiratory functions, which is why you cannot overdose, the brainstem contains some of the main analgesic pathways, and so we will be discussing that a bit, in particular in the pons in the medulla. The other cannabinoid receptor that has been well characterized is a cannabinoid 2 receptor. It was first cloned and sequenced in 1993. These receptors are found primarily in the immune system and not nearly as abundant in brain as CB1 receptors. So they're well known to be expressed in spleen, the pancreas, tonsils, and in all of these, they're often found on the mast cells and macrophages of the peripheral system. Now, there are other putative cannabinoid receptors, but they have not been well characterized, hence I won't be talking about those at all. The CB2 receptors are, in fact, primarily responsible for mediating cytokine release within the immune system. So both of these cannabinoid receptors are G protein coupled receptors. And so on the right-hand side then, the 7-transmembrane domain, let's see, I don't really have a pointer. You see the 7-transmembrane domain protein here, and when the cannabinoid binds to the receptor, it inhibits calcium influx as well as potentiates potassium influx, and it is through this mechanism that cannabinoids are going to cause a decrease in neurotransmitter release. CB1 and CB2 receptors also activate other pathways, including adenylate cyclase, inhibiting adenylate cyclase pathway, or stimulating the MAP kinase pathway. And in this way, cannabinoid receptors can also control gene expression. So the first endogenous cannabinoid that was isolated is anandamide, and you can see the structure here. This was in 1992. Once the cannabinoid proteins or cannabinoid receptors were identified in brain, it became clear that there must be some sort of endogenous ligand, and so the search was on. This was the first one they found. It's not in a very, when it's measured in brain, the 19 picomole per gram is a very low concentration, and as you'll see, the 2-arachidonoglycerol is the main endocannabinoid neurotransmitter in brain. Anandamide is a partial agonist at cannabinoid receptors, which means it only activates about half of the receptors. It's also known to activate the TRPV or the vanilloid 1 receptors. 2-arachidonoglycerol was subsequently identified, isolated. Concentrations of this are much higher in brain, and so there's about 12 nanomoles per gram. And so it's about anywhere from 100 to 1,000-fold greater concentrations in brain than anandamide. And it's actually similar to the levels of GABA and glutamate in brain, just to give you an idea, the two main neurotransmitters. And unlike anandamide, 2-arachidonoglycerol is a full agonist, and therefore it activates all receptors. And it is considered the main neurotransmitter in brain that interacts with the cannabinoid receptors. Now, for each of these endogenous cannabinoids, there are different pathways to produce them as well as inactivate them. The first one we're going to look at is a direct conversion of N-arachidonyl phosphatidylethynolamine, which I've abbreviated as NAPI. And so within a cell, you have the N-arachidonyl phosphatidylethynolamine that is phospholipase D converts it directly into anandamide. And then anandamide is broken down relatively quickly by fatty acid amide hydrolase and produces arachidonic acid and ethanolamine. One important part about FA is that it tends to appear only postsynaptically, which is in contrast to 2-arachidonoglycerol. And so that probably has different biochemical processes that it regulates as compared to 2-arachidonoglycerol. For 2-arachidonoglycerol production, there are several potential precursors. And what we're going to look at here is just the biosynthesis from diacylglycerol hydrolysis. And so you have your DAG and then your DAG lipase, and it converts it straight to 2-arachidonoglycerol. In contrast to anandamide, 2-arachidonoglycerol is broken down by MGL, or monoacylglycerol lipase, and it also forms arachidonic acid and then just the glycerol. And as I said, MGL is segregated presynaptically, and so there seems to be two distinct pathways by which the endogenous cannabinoids can affect biological processes. And so how does this relate to pain? Well, in the normal transmission of pain, you have a painful stimulus, such as you smash your thumb, that's going to enter your dorsal horn, cross over to the contralateral side, and then shoot up the brainstem to the thalamus before it goes on to the cortical regions of the brain, including somatosensory cortex and other areas. The ascending pathway also relays information to the periaqueductal gray in the brainstem. And this is an important part of the descending pain modulating pathway as well. And so the ascending pathway actually interacts with the descending pathway. And I mention this only because there is a high density of CB1 receptors located in the periaqueductal gray. And we're also going to see the medulla. And so if we just look at the brainstem, that's what I attempted to do on the right-hand side here, is to just to magnify that, showing the periaqueductal gray and then the medulla. And so the black arrow being the ascending pathway, and then the green arrow going down be the descending anti-nociceptive pathway. So now if we just look in the periaqueductal gray and the descending anti-nociceptive pathway, what we see is different neurons converge in a particular location. And what is thought to occur is that the descending neurons are active all the time. And these GABA neurons feed onto it to inhibit them from firing. But if we take a close-up view, then what we see is that whenever a pain stimulus comes in, it causes strong depolarization of the ascending pathway, and this opens calcium channels. And that calcium influx induces the production of diacylglycerol. And then DAG lipase takes diacylglycerol, hydrolyzes it, and forms 2-arachidonyl glycerol. And so now we have our endocannabinoid here, and that gets released into the synaptic cleft and activates cannabinoid receptors on the presynaptic side. The activation of CB1 receptors inhibits presynaptic calcium influx, and that means that GABA can no longer be released, and this causes a disinhibition of the anti-nociceptive signal and allows for the signal to go down and produce analgesic effects. And so this is a particular mechanism by which depolarization induces a suppression of inhibition, or DSI. It's also a form of long-term potentiation in learning and memory. So some of the unique characteristics of the endocannabinoid system include the fact that they are lipid metabolites, that is, they're formed from internal lipid constituents of the cellular membrane. And this makes them extremely hydrophobic, and that limits their mobility. Unlike other neurotransmitters in brain, endocannabinoids are not pre-formed and stored in synaptic vesicles, but rather they are produced on demand, or de novo. And a third unique characteristic is that, unlike other neurotransmitters, endocannabinoids tend to act in a retrograde manner, as we just went through on the slide before this, whereby they are they're produced postsynaptically, and then they act in a retrograde manner to affect the presynaptic neuron. So as we shift into the potential therapeutic properties, all of this will become clearer why I just went through everything that I did, I hope. So we're going to talk briefly just about the plant-based, or the phytocannabinoids and synthetic cannabinoids. And we'll go over the cannabinoid pharmaceuticals, as well as the randomized clinical trials that have been conducted to date on the potential efficacy of cannabinoids for pain management. So whenever the cannabis plant is smoked, you're not just getting one molecule or another, you're actually getting around 400 molecules in your system, and of these, about 100 of them could be classified as cannabinoids. And cannabinoids are, in fact, unique to the cannabis plant, but only 2 of these 100 compounds have actually been well characterized. And those are the 2 we're going to talk about. Synthetic cannabinoids are simply those that are made in a lab but are very similar to the phytocannabinoids and their administration induces the same effects as THC, which is the main psychoactive ingredient found in cannabis. So the phytocannabinoids include cannabidiol. It is a non-psychoactive component of marijuana. And rather than actually have psychoactive effects, it is thought to modulate the effects of THC in 3 different ways. The first being it has a slight affinity for the cannabinoid receptors. Thus, it signals receptors as an antagonist or reverse agonist in the presence of THC. It can modulate the signal transduction by perturbing the fluid membranes and thereby making it so that the cannabinoid receptors. Something happened. And then third is that they can inhibit the. Thanks. Sorry.
You did something, I lost it here. We don't need that up there. It's meant to be removed. Okay, okay.
It also potently inhibits particular metabolic pathways, and by doing so, it can block the hydroxylation of THC to its metabolite. And this is important because the metabolite is actually 4 times more psychoactive than THC itself, and it's also 4 times more immunosuppressive. So cannabidiol is now an FDA-approved medication, also known as Epidiolex. It's approved in children as young as 2 years old for particular types of seizure disorders. It is from GW Pharmaceutical. It's a botanical extract. The dose is 2.5 milligrams per kilogram, and so that amounts to about 700 milligrams per day for an 150-pound person. Its cost is about $1.20 for 10 milligrams, and the typical dosage is about 2.5 milligrams per kilogram twice per day. It was approved in June. It's a Schedule 5 drug, which means it has a very low abuse liability. So other Schedule 5 drugs would be like buprenorphine for opioid use disorder. And there are some reported side effects with it, including decreased appetite and other GI effects. And it can also impact sleep, and it may have other effects that have not yet been realized because it's only been on the market for a short time. So then the main psychoactive ingredient found in marijuana is THC. THC is similar to the endogenous cannabinoids, anandamide, in that it is only a partial agonist at the cannabinoid receptors. And so while anandamide activates around 50% of cannabinoid receptors, THC activates around 20%. It is responsible for the psychoactive effects of cannabis, and so if you were to smoke marijuana that had all the THC removed, you would not feel high. But that would in fact be beneficial for some people because it's these psychoactive effects that are the most frequently reported reason for people discontinuing the use of medical cannabis, especially among people who have not used marijuana in the past. THC is a well-known analgesic compound. It's an antispasmodic, and it's also a muscle relaxant. It's 20 times more powerful than anti-inflammatory power of aspirin, and it's twice that of hydrocortisone. And so taking cannabinoids either through the inhaled route or orally may provide an option for treating pain that has responded poorly to conventional pain therapies. In fact, THC was first evaluated in a pain model in the 1970s, And here we see the results of that study where they compared, if you look on the y-axis, you have the pain reduction score, and on the x-axis is just time, which is in hours. And so individuals received placebo, 120 milligrams of codeine or 20 milligrams of THC, and their response to pain, as you can see, with the placebo was very minimal, but for both the codeine and the THC, they were about equally effective at reducing pain in cancer patients. Now, there have been a number of randomized clinical trials of cannabinoids for pain, and I'm going to briefly summarize those, but one of the interesting facts that I found doing this research was that among individuals who use medical marijuana, the vast majority of them report using it for the relief of pain. And so I broke it down into 3 different pain areas, including neuropathic pain, cancer pain, and musculoskeletal pain. Within the neuropathic pain, a recent meta-analysis that included randomized clinical trials looking at dronabinol, which is THC. Nabilone is a synthetic analog of THC, or the combination of THC and cannabidiol in patients who had moderate to severe pain, defined as greater than or equal to 4 on a numeric rating scale. And this included individuals who had multiple sclerosis. And this meta-analysis concluded that cannabinoids produce a significant reduction of the intensity of pain after at least 2 weeks of treatment. In cancer pain, the combination of THC and cannabidiol together have been the most extensively studied. It has been conditionally approved in Canada and some European countries for the treatment of cancer pain. And in the US, it's currently in phase 3 trials. And so there is certainly some positive results and the potential for it to be FDA approved in the future. And in the realm of musculoskeletal pain, there are 118 studies included in a systematic review. And by and large, they found that it was effective for the treatment of musculoskeletal pain. Of the randomized clinical trials that the authors looked at, 85% of them indicated that it was effective. 17% found mixed signals. 9% found that it was not. And 5 studies demonstrated that as many studies do these days, were just unclear findings. So while all this sounds positive, there are a number of limitations to these clinical trials that have been conducted to date, and really there are very few to know the gold standard clinical trials that have really evaluated whether or not cannabis or cannabinoids are in fact effective for treating pain. And so some of these limitations, I broke it down into 2 areas. One, just looking at any route of administration. So this is whether you used an FDA-approved treatment, such as an isolated THC or cannabidiol, or you have used cannabis, whether it's smoked or vaporized or otherwise consumed in orally. And then there are clinical trials that just looked at the actual plant, and so smoking it or vaporized cannabis. Now, of all studies, most of them have a very, very short duration, less than 2 weeks, which is well below the standard randomized clinical trial duration of 12 weeks. They suffer from very small sample sizes, and many of them lack control groups, and so you don't get a good comparison. Now, of those studies that have included only the smoked cannabis, most of these, if not all of them, have been conducted in cannabis-experienced patients only, although this is probably a protocol requirement. The biggest issue with smoked cannabis is that it's almost impossible to standardize the cannabis that's being used, and so the amount of THC versus cannabidiol is very difficult to control. And because of that reason, and a reason we'll see in the next few slides, it's also very difficult to quantify how much of a dose is actually delivered when you smoke it. And also because you are smoking something, it's very difficult to actually be blind to who gets what. There is not a good smoked joint out there that you wouldn't be able to easily determine that this is not marijuana, it's in fact a placebo. So one of the cannabinoids that I included and just talked about, which I didn't say by name, is Sativex. Whoa, that wasn't supposed to happen. There we go. So, or Sativex. And so it's a whole plant extract, and it contains both cannabidiol and THC, and it's a spray. And so each spray is about 100 microliters, and it costs about $2.50 for each spray. And a typical dose is somewhere between 6 to 12 sprays per day. It is not currently FDA approved, but it is in phase 3 trials. And it is approved in Canada as an adjunct treatment for spasticity associated with multiple sclerosis. The other potential medicinal effects, or the well-known medicinal effects of the currently FDA-approved medications, include appetite stimulation and controlling of nausea. In general, it's thought that the inhalation route is the best, or smoking cannabis is better than receiving the isolated THC, but for some people, smoking is also nauseating. And tolerance does develop to these effects. And so Marinol is the FDA-approved version of THC. It's known as dronabinol, is the generic name. It is a synthetic THC, and it comes in 3 different doses. It's fairly inexpensive, and it's currently FDA approved as an antiemetic, as well as for AIDS wasting syndrome, or as an appetite stimulant for AIDS wasting. It's a Scheduled 3 drug, which means that it's not considered as potentially abusable as those at Schedule 2, but certainly more abuse than something such as cannabidiol, which was Schedule 5. Sesamet is very similar. It's a racemic mixture of a synthetic THC analog, and so it has very similar effects. It's a bit more potent than Marinol, and so the dosage is lower. It's 1 milligram per capsule. It's taken typically 3 times per day, and approved as an antiemetic, just as Marinol was. And this is a Schedule 2 drug because it is a bit more potent. So there have been other randomized clinical trials of potential medicinal effects of these cannabinoids, and depending on which particular indication they looked at, they found different evidence of efficacy. Overall, there is substantial evidence of efficacy for the use of cannabis and chronic pain in adults as an antiemetic for the treatment of chemotherapy-induced nausea and vomiting, at least for the oral THC, or the FDA-approved version of dronabinol. And it's also improved spasticity. And again, this is just the oral version and not the smoked cannabis. Now, there is some evidence that is also useful for short-term sleep outcomes in those who have obstructive why am I blocking on it? Sleep apnea, sorry. Fibromyalgia, chronic pain, and multiple sclerosis. And these data come primarily with the use of the Sesamet. And there's limited evidence of efficacy, even though it's been approved for increasing appetite and decreasing weight loss associated with HIV. And it also doesn't improve clinician-measured spasticity and multiple sclerosis. All right, so a research summary, just looking at all the studies that have been done. The National Academy of Sciences in Engineering and Medicine looked at over 10,000 abstracts to determine if there was any conclusive or substantial evidence for the use of cannabis in treating chronic pain in adults. And they concluded that in adults with chemotherapy-induced nausea and vomiting, that the oral cannabinoids were the most effective, and that cannabis or cannabinoids increase the likelihood of significantly reducing pain symptoms in adults. That the oral cannabinoids were good for spasticity and multiple sclerosis. And for the effects of cannabinoids for all of these were really quite modest. And there really just isn't enough data out there to make these sort of conclusions, though they did. So when you're considering the use of cannabinoids for pain or any other indication, it's important to really realize two things. One is that if you're going to use an FDA-approved medication, then you are giving just the actual compound that's in the bottle, and it's well controlled. On the other hand, medical marijuana comes in many forms, whether it's concentrates or the edibles or the marijuana plant itself, and there's quite a wide variability in the amount of cannabidiol versus THC in these different products. And so while using oral or inhaled cannabinoids may prove to be beneficial, it's important to realize that the oral administration of cannabinoids has a much different onset of action and duration of action. And so in the graph here, what we're looking at on the y-axis is plasma concentrations of THC, and on the x-axis is time, again in hours. And so in blue, you see oral administration of 20 milligrams of THC, that the peak effects don't occur until about 1 hour, and then they persist for up to 6 hours. While smoked cannabis or inhaled in red here, you can see that the onset of action is really quite rapid. It occurs within 5 minutes, and then it dissipates much more quickly than oral. And it's very similar to intravenous THC administration, where you get the very fast onset of action, and then the effects also dissipate more quickly than for oral. And much of this is because when you take it orally, you are going to have first pass metabolism, and so it's going to travel through the GI tract to the liver, where it's going to be metabolized before it enters the bloodstream. However, even within people who smoke marijuana, there's quite a lot of variability between individuals. And so, very similar graph here where we're looking on the x-axis at time, and on the y-axis is just the concentrations of THC. And these are 7 different subjects who had smoked marijuana in a lab, and they measured their concentrations at different time points. And so they started smoking at 0 on the x-axis, and for about 20 minutes they smoked, and you can see just how wide the variability is. And there's a number of reasons why this can happen. It includes the experience of the individual smoking, how much they actually inhale, how many puffs they're taking, and how long they hold the smoke in their lungs are all going to affect the bioavailability of smoked marijuana. And so while you get about 10% bioavailability for the oral route, you get about a range of between 2 and 50% bioavailability in the smoked route. All right, so marijuana is now legal in 11 states for adults over the age of 21 and legal for medicinal use in 33 states. There are some challenges associated with recommending the use of cannabis as a medicine or with any plant for that matter. And these issues, of course, not specific to cannabis, but really the use of any whole plant as a medicine. And again, it's the quality of the product that's being produced, the uncertainty regarding how to actually titrate or dose somebody with medical marijuana, the lack of control over what is in the product. And as you can see here, it just shows you the concentrations of THC in different preparations of cannabis. And so the THC level can vary widely depending on which product you're going to use. So clinical advantages compared to opioids at least. Risk of overdose and risk of abuse are the two areas I want to touch on. And so while I'm sure everybody's aware of the number of opioid overdose every year, it's virtually impossible to overdose from cannabinoids. And I have an LD50. Yeah, so the estimated lethal dose of intravenous dronabinol, or if you were to inject dronabinol, is 30 milligrams per kilogram, which is really quite a whopping dose. On the other hand, the abuse potential of taking THC orally is very low, and this is in fact because of the pharmacokinetics of oral administration that we saw on the slide before, where the onset takes about an hour and then the effects dissipate over time more slowly. And so you don't get the immediate high that you do when you smoke cannabis with oral THC. And on the other hand, cannabidiol, the abuse liability of it is exceedingly low, as it is not a psychoactive substance, and so it doesn't appear to produce the rewarding effects that THC does. Now, so I've said a few times that there's been a lot of studies done, but they're not very good, and so I'm somewhat skeptical myself, but there is a great potential for cannabinoids to help as a pain management technique. And here I just list some of those reasons. The first is that it can decrease the use of opiates as well as other analgesics such as NSAIDs. It can also synergize with opioids. And so when we were looking at the ascending and descending pain pathways, mu-opioid receptors are also within that pathway, but on different neurons, at least some different neurons. And so there's the potential for opioids to produce some analgesic effects by activating one pathway, cannabinoids to produce the same similar effects on a different pathway, and thereby you could potentially lower the effect of those for both of these drugs to achieve pain relief if they do synergize. They also have the potential to increase pain relief in people who are unable to achieve effective relief with opioids because they are not activating the same pathway, or in those who have developed tolerance to opioids. And finally, because it does have a lower abuse potential, use of cannabis is certainly going to have the potential advantage of not being associated with the adverse outcomes that opioids do. Now, there are a number of reasons why you should consider not using medical marijuana. And one of those areas is psychiatric conditions. So certainly individuals who have either long-term use of cannabis or a pre-existing diagnosis of some mental health disorder, you would want to use it very cautiously. Certainly I would not recommend anything with adolescents, especially those who are under stress and may be particularly susceptible to developing things like psychosis. I did say that THC has a low abuse potential, and in fact, it's estimated that about 9% of people who smoke cannabis will go on to develop a cannabis use disorder. And so certainly you want to be cautious before using medical marijuana in individuals with a history of substance use disorders. At a minimum, you would want to monitor them more frequently. Smoking pot or marijuana can also cause problems with the lungs, especially in people who have ongoing problems. And it's also known to produce hypertension and other cardiovascular effects. It can also potentially impact the liver adversely, and so you'd want to use caution in anybody who has liver or renal diseases. And just like most drugs, I don't think you'd want to give it to pregnant or nursing mothers. So the most common side effects fall into these different areas, and they include the unwanted psychoactive effects. As I'd mentioned earlier, the main reason people stop using cannabis for pain or any other condition is the unwanted psychoactive effects, which is in contrast to people who smoke pot for recreational use who are actually seeking that. There's certainly short-term memory loss that has been well established occurs with the use of cannabis, and this only means that while you are high or under the influence, that you would have some sort of effect on your memory. It can impair psychomotor functions, and we'll go over each of these. So the unwanted psychoactive effects are typically dose dependent. So the more you smoke, the more high you will feel. Tolerance does develop to these effects. And in general then, if you were to be looking at strains of marijuana that are available, you would want to look for those that have high levels of cannabidiol or CBD and low levels of THC, because again, THC is the main psychoactive ingredient. And even if they do occur, it's often reassuring to know that they are short-lived and that they will dissipate in a short time. So as far as the short-term memory, we had talked about the hippocampus earlier, and that's exactly why THC is thought to produce short-term memory loss. And again, for this, you just want to look for high cannabidiol levels and low THC levels. Psychomotor function, especially in the elderly, you might want to be careful. It may be more susceptible to falling. Because reaction times are impacted, it's not a good idea to operate heavy machinery or drive a vehicle. And in fact, they are currently developing a breathalyzer for THC, and so you may be pulled over one day and be asked to blow in a breathalyzer so they can determine whether or not you've used marijuana. Tachycardia is dose-related, just like most things are dose-related, and it's just something that would need to be monitored. But certainly in those who have cardiac disorders, you'd want to be very careful. And just as it's dose-related, it's also subject to tolerance, and so over time you will see a decrease in this. The bronchitis and lung irritation is only going to be with smoked cannabis, certainly not going to be associated with oral THC administration. There is some evidence of a link between cannabis and lung cancer, but certainly nothing consistent and nowhere near like it is for cigarettes. Increased appetites, it's well known to increase appetite, and that's in fact why dronabinol is approved as an appetite stimulant and for wasting syndrome and HIV/AIDS. There's very rare that this hyperemesis would occur, but it's just that some people must have a high number of receptors in particular brain regions, and so it causes them to vomit rather than producing anti-nausea effects. And for this, you would just want to immediately discontinue using it. And for males in particular, cannabis may decrease sperm count or cause other abnormalities, although this will return to normal after a few months of not using. And so just a few final thoughts. First, that finding an alternative pain treatment would have major benefits, not just for individuals, but also society, given the increasing prevalence and enormous cost of pain. It's really remarkable that 1 in 5 American adults suffer from chronic pain, and the cost of that is really astronomical. And in fact, it's higher than the costs for cancer, Alzheimer's, and cardiovascular disease. And given the current opioid epidemic, any novel medication treatment that can reduce the use of opioids and thereby reduce the number of Americans who are becoming dependent on them and the number of Americans who die every day from the overdoses would obviously have obviously benefit all of us in many ways. And I would assume there are no questions.
We have one question
Ah.
from the audience.
What effect could medical cannabis have on someone with spinocerebellar ataxia? That's a very specific question. Huh.
That came in from offline.
Yeah, I'm not familiar enough with spinocerebellar ataxia to be able to respond, unfortunately. We have a few seconds, so just mention that cannabis can in fact cause a withdrawal symptom or withdrawal symptoms, and so it's important to be aware of these as well. And these are going to occur in individuals who have been using marijuana for a good 6 months or so and using it every day. But it's important to just be aware that this does occur. Oops. And so that's what we're showing here is on the x-axis is just time again, but here we're looking at days of abstinence. And on the y-axis is just the withdrawal discomfort score. And so in people who were smoking pot every day and then stopped quite some time ago, their withdrawal discomfort score is low. But in people who are currently using and then stop using right around day 1 through 3 here of abstinence, you see that the scores are quite high and that this can actually persist for up to about 3 weeks. And these symptoms include things like sleep disturbances, as well as a few others, but in my experience, talking to individuals who have gone through it, it's the sleep disturbances that tend to be the most difficult to overcome and drive people back to using marijuana when they're trying to stop. So, and it's all also similar to the intensity associated with tobacco withdrawal. And that's all. Thank you.